Welcome to this medicine masterclass in which we will be having a case-based discussion around mitral stenosis. Mitral stenosis is characterized by the narrowing of the mitral valve orifice, restricting blood flow from the left atrium through to the left ventricle. The classic clinical manifestations are exertional dyspnea, orthopnea and PND, particularly from cardiac failure. Palpitations are common, in particular atrial fibrillation, and consequently thromboembolic disease, the development of blood clots, and fatigue and weakness, especially during increased physiological demands such as exercise or pregnancy. So let's take a case and discuss the cardiovascular examination findings and then have a discussion. So in mitral stenosis, on inspection of the precordium, you'd expect a normal precordium with no scars. On palpation, the apex beat was not displaced, would be found in the normal position in the fifth intercostal space, left midclavicular line, and would be tapping. A left parasternal heave would be noted because as the valve is stenotic, there is a thickening of the wall resulting in a parasternal heave. On auscultation, heart sounds 1 and 2 would be audible, and the murmur is described as a low-pitched, rumbling mid-diastolic murmur heard with an opening snap. And this is best heard over the mitral region, and it's accentuated with the patient in the left lateral position on expiration. The pulse in such patients is usually irregular, normal in volume, and you can also see a malar flush, a reddening of the upper cheeks. The JVP would not be expected to be elevated unless there's consequential heart failure, and would have a normal pulsatile waveform, and similarly you would not expect peripheral edema unless there's the presence of heart failure. So putting all this together, you'd comment that Mr. or Mrs. Jones presents with shortness of breath and palpitations. The patient was comfortable at rest, and I believe that the patient has signs consistent with mitral stenosis. On inspection, the precordium appeared normal with no scars. The apex beat was not displaced, found in the fifth intercostal space, left midclavicular line, and was tapping in nature. A left parasternal heave was noted. On auscultation, heart sounds 1 and 2 were present. A grade 3 low-pitch rumbling mid-diastolic murmur was heard with an opening snap, best heard over the mitral region, accentuated with the patient leaning in the left lateral position on expiration. The pulse was 72 beats per minute, irregular. As it was irregular, offer a range, so between 60 and 90 beats per minute. There was no evidence of radioradial or radiofemoral delay, and I noted a malar flush, and the JVP was not elevated, and there was no evidence of peripheral edema. So what are the differentials associated with mitral stenosis? Mitral stenosis, as we mentioned, is a diastolic murmur, so think about other diastolic murmurs. Mitral stenosis and tricuspid stenosis, aortic regurgitation and pulmonary regurgitation, and mixed mitral valve disease. What are the causes of mitral stenosis? We can think about primary causes. That's where the mitral valve itself or any component of the mitral valve apparatus, whether that's the leaflets, the chordae tendineae, the papillary muscles, or the annulus, can become diseased or degenerate, and that's known as myxomatous degeneration. Rheumatic heart disease and infective endocarditis can also result in mitral stenosis, and drugs such as ergotamine, bromocriptine, pergolide and cabergoline, drugs which are now going out of fashion, can also result in valvular fibrosis and mitral stenosis. Coronary artery disease causing regional wall motion abnormalities can also result in a distorted mitral valve apparatus and affect its closure. Investigating using the B-Fish approach, the bloods, the fluids, the imaging, the special tests, and then reviewing the values of these tests to monitor disease progression or regression, let's start by investigating the bloods. A full blood count, using these, would be useful as baseline markers, particularly looking for signs of anemia which may precipitate some of the symptoms. A CRP and an ESR can be useful in infective endocarditis and rheumatological conditions or rheumatic fever, and blood cultures will be important if you're thinking about infective endocarditis. An ECG is very important to rule out or rule in the presence of atrial fibrillation. The stenotic mitral valve increases the pressure in the left atrium, and as a result, the left atrium enlarges, As the left atrium enlarges, it increases the foci, the potential foci of aberrant electrical circuits, and therefore increases the propensity to develop atrial fibrillation and indeed other arrhythmias. The valvular disease can also result in underlying ischemia and left axis deviation. The key investigation is echocardiography, which would allow you to determine cardiac contractility, the ejection fraction, renal wall motion abnormalities, and chamber sizes. In this condition, if you're thinking about the development of blood clots as a result of atrial fibrillation, not only would they require a transthoracic echocardiogram, but may require a relatively invasive transesophageal echocardiogram to assess the chambers more clearly, in particular the left atrial appendage, to look for signs of a thrombus. Other investigations could include a cardiac magnetic resonance, which would allow you to look at blood flow patterns in more detail, as well as a coronary angiogram. If the patient would require surgery, a coronary angiogram would allow you to determine whether or not there's the presence of coronary artery disease, and so a coronary artery bypass graft can be performed at the time of surgery. So managing these patients should be holistic, with a patient-centered approach involving a multidisciplinary team, and there's a conservative medical, interventional and surgical approach that can be used. Conservatively, the patient should be educated and their psychological concerns should be addressed. Smoking and alcohol cessation and weight loss should be advocated if indicated. Optimize their comorbidities, advocate fluid restriction if there's the development of heart failure, offer them driving advice, in particular if their condition is associated with arrhythmias or syncope, and prepare them for surgical intervention. Medically, if they develop heart failure, they would require treatment, and if arrhythmias develop, they would require the appropriate treatment. Atrial fibrillation may require a rate or rhythm control and an anticoagulation strategy. And endocarditis would require aggressive antibiotic management. What about the surgical options? We'd refer to the European Society of Cardiology and the European Association of Cardiothoracic Surgeons joint guidance, and we'd first of all determine whether the patient is symptomatic or not. If in mitral stenosis the patient is symptomatic, and if there's a contraindication to a smaller procedure called a percutaneous mitral commissurotomy, offer surgery for a valve replacement. But if there's no contraindication or they're high risk, offer a PMC or a percutaneous transvenous mitral commissurotomy. If the patient is asymptomatic and not high risk, perform exercise testing to see whether they develop symptoms. If they do, consider surgery. Or if there's hemodynamic decompensation or a high risk of embolization, then consider surgical intervention. Otherwise, such patients can be observed. In summary, we've presented the definition, the presentation of mitral stenosis, the signs and symptoms, the differentials, the investigations, the management and the guidelines, and had a case-based discussion. Thank you for attending this medicine masterclass.